So good morning, everyone. My name is Dr Wang, and today I'm going to talk about the use of CT perfusion study for acute ischemic stroke. So first, we are going to talk about why we need CT perfusion study for management of acute ischemic stroke. And then I'm going to introduce some fundamental hemodynamic parameters for CT perfusion study. And then we are going to talk about how are we going to use CT perfusion study in clinical practice, and also some pitfalls and limitation of CT perfusion study. So let's start with the case. This is a 67-year-old man come to the ER with right hemiplegia and left gaze deviation. And he also has right hemianopia and global aphasia. The time from last known well is 11 hours ago before he fell asleep. So he woke up with all this deficit. And his NIH stroke scale is 20. On CTA, the occluded vessel is on left M1 segment. So let's look at his CT scan. Could anyone tell me where is the lesion on this CT scan? So how are we going to use this as a prediction for prognosis for our patient? So as this is a MCA stroke, we can use aspect score to quantify the severity of the stroke. So for aspect score, MCA territory was divided into 10 regions, which include 3 subcortical regions. There is the head of caudate and lentiform nucleus and internal capsule. And just external to the lentiform nucleus, there is the insular ribbon. And external to insular ribbon, there is M1 to M3 cortex from anterior to posterior. And just rostral to this cord, there is M4 to M6 from anterior to posterior. So to calculate aspect score, 1 point will be subtracted from 10 for any kind of ischemic change, early ischemic change on non-contrast CT, like hypodensity or focal edema for any defined region. So for our patient, he had hypodensity over the head of caudate, lentiform nucleus, and internal capsule. So it's a -3 points, so his aspect score is 7. And how does this score going to tell us about our patient? So we can look at this figure. So this is a figure that uses a dichotomous classification, which classified patient with aspect score 8 or more as high aspect score, and patients with 7 or less defined as low aspect score. So we can see that patients with higher aspect score have a better outcome scaled by modified ranking scale, which is a scale for functional outcome for stroke patient. However, we can see that there is no treatment modified effect for different aspect score, which means even patient with low aspect score, they can still be benefit from, for this study, it's intravenous TPA, so they can still benefit from aggressive treatment, even if they have low aspect score, like our patient. And what about, but however, patient with low aspect score, they do have a higher chance of parenchymal hematoma and symptomatic intracranial hemorrhage after they receive intravenous TPA. But as patients have lower aspect score, can still receive benefit from intravenous TPA. A low aspect score is never a contraindication for intravenous thrombolytic agent treatment. And what about patient who receive endovascular treatment? So this is another study from 2015. There's 500 patients being enrolled. And we can see from this graph, most patients who receive intervention, which is an endovascular thrombectomy, have a better outcome compared to patients who receive control, which is a standard medical treatment, which include intravenous TPA. So we can see there's a trend of improved outcome from there's more patients with lower modified Rankin scale score, which means they have a better functional outcome at 90 days. And last patient with a higher modified Rankin scale score, which means last patient have a worse outcome at 90 days. However, patient with modified Rankin scale score of 6 are about the same. So 6 means patient died at 90 days. And in this study, they also did a subgroup analysis. So we can see patients with higher aspect score have a significant difference that favored endovascular intervention. However, patients with low aspect score, they have the difference between control and endovascular intervention is non-significant. So, however, this may also due to the small sample size of patients with low aspect score. So we need more data to know whether patient with low aspect score, like our patient, can be benefit from endovascular treatment. So this is another study from JAMA, and they want to know patient with low aspect score from 2 to 5 who underwent mechanical thrombectomy, whether they will be benefit from this aggressive treatment. So we can see even patient with low aspect score, like from 2 to 5, they can still be benefit from mechanical thrombectomy if they go through a successful recanalization. So, but besides from low aspect score, our patients still have another issue that we have to address is the prolonged time from symptom onset. So this is a graph that showed us how time can affect endovascular treatment's effect. So we can see about around 7 hours, the benefit of endovascular treatment over medical therapy disappear. And for our patient, it's 11 hours. So current guidelines suggest that patient within 6 hours is a criteria for eligibility of thrombectomy, but our patient has a time from symptom onset of 11 hours. So after 6 hours, we need a more reliable tool to select patient who might be benefit from more aggressive treatment. So this is why we need CT perfusion study to help us select this kind of patient. So what we are looking in CT perfusion study is that we want patient with a small ischemic core and a large ischemic penumbra, which means a large area that is potentially reversible. And now we are going to introduce some fundamental parameters for CT perfusion study. So on this graph, first we can see this mean transit time. So mean transit time is time for contrast pass from intracranial artery to intracranial vein through capillary bed. And there's Tmax, which is the time that contrast reach the maximum concentration intracranially. And the area on this curve is cerebral blood volume, which is the volume of blood flow to per 100 gram brain tissue. And the slope of this upgoing part of this curve is cerebral blood flow, which also equal to the cerebral blood volume divided by mean transit time. So with a patient have a large intracranial artery just be blocked, the blood supply for that certain area will come from collateral blood flow rather than the major artery. So it means when this blood flow comes from a collateral blood supply, the mean transit time and time to maximum will increase because it will go through a longer path rather than the major artery originally. So Tmax and mean transit time will increase. However, cerebral blood volume will essentially remain the same unless there is a true ischemia happen. So because that ischemia, that certain area still receive blood flow from collateral blood supply, the cerebral blood volume will be essentially the same. And the cerebral blood flow is equal to cerebral blood volume divided by mean transit time. It will decrease. So how is this parameter going to present on CT perfusion scan? So this is the CT perfusion scan for our patient. So we can see on the right of this graph, we can see this area of delayed Tmax. So on the color scale, the red color means the higher value and blue color means a lower value. So there is on left hemisphere, left MCA territory, there's the large area of delayed Tmax. And we can also see there's a delayed mean transit time on left MCA territory. And for cerebral blood volume and cerebral blood flow, there's a decrease at left basal ganglia area. And notice that cerebral blood volume and cerebral blood flow is presented as a relative value rather than an absolute value. So this value is compared to normal brain tissues, blood volume and blood flow. So how are we going to transform this graph to a better picture to help us to determine which patients are going to be benefit from more aggressive treatment? So nowadays, the ischemic core is defined as cerebral blood flow less than 30%. This is the most widely validated definition now. So studies have been looking up like whether cerebral blood flow or cerebral blood volume which is better as a predictor for cerebral blood flow, so for ischemic core. And the study found out that cerebral blood flow is actually better than cerebral blood volume regarding determining the ischemic core volume. And for ischemia penumbra, which is the area that is potentially reversible, nowadays the most widely validated definition is time to max delayed more than 6 seconds. So how are we going to use this into clinical practice? So there are 3 major trials and the guideline and the criteria based on this trial. So the first is Diffuse 3 trial. So, and also all of this trial, they use CT perfusion study to look at patients with small ischemic core and high mismatch ratio, which means they have a large ischemic penumbra, the area that we can reverse the damage, and the small, really infarct tissue. So for Diffuse 3 trial, the symptoms to treatment time was extended to 16 hours, and patients should have a stroke severity more than 6 NIH stroke scale and age between 18 to 90. And pre-stroke function should be better than 2 points of modified Rankin scale. And this is the important process. On CT perfusion study, they should have a ischemic core volume less than 70 milliliter, and the mismatch ratio, which is ischemic penumbra volume divided by ischemic core volume, more than 1.8. And the absolute mismatch volume should be more than 15 milliliter. And there is Dawn trial, which further extend the time from symptom onset to 24 hours. And patients should have a more severe stroke of an IH stroke scale more than 10. And there's no criteria for age, but on the original trial, the median age is 69 and the interquartile range of the age is 55 to 84. And patients should have a pre-stroke modified Rankin scale 1 or better. And this is the tricky part. So instead of the ischemic penumbra volume, they use the symptoms as a predictor for the potential reversible area. So patient with age 80 or older, they should have a NIH stroke scale more than 10, and they should have an infarct volume less than 21. And for patient with age less than 80, with an NIH stroke scale 10 to 19, they should have an infarct volume less than 31. And if their symptom is more severe, which means the potential reversible area is larger, with an IH stroke scale 20 or more, they should have an infarct volume less than 51. And the third trial is extend trial. So this trial is for intravenous TPA. And they extend the time from symptom onset from 4.5 hours to 9 hours. And notice that at this trial, the definition of symptom onset for patients who woke up with a stroke is defined as the midpoint during the sleep. So this definition buys us more time for patient. And in the original trial, the inclusion criteria is NIH stroke scale 4 to 26, and the median age is 74, and there's no limitation for pre-stroke function. And regarding the city perfusion study, the criteria is less strict than Diffuse 3 trial, which also need a ischemic core volume less than 70, but only need a mismatch ratio more than 1.2, and the absolute mismatch volume more than 10 milliliter. So let's look at our patient, whether our patient could be eligible for all these criteria. So for Diffuse 3, our patient is within 16 hours with a severe enough stroke symptoms and with a small enough ischemic core and a large enough mismatch from ischemic penumbra and ischemic core. So it's a match. And for Dawn trial, of course, it will be within 24 hours. And our patient is 67-year-old. So for 67-year-old with an IH stroke scale 20, it should have an infarct volume less than 51. So it's also a match. And for extend trial, the time from symptom onset should be within 9 hours. However, because of our patient woke up with the symptoms and the definition of symptom onset is defined as the midpoint between the sleep, during the sleep. So our patient might be eligible according to this criteria. And the symptom is within 4 to 26 of an IH stroke scale. And of course, this mismatch will be a match as extend trial is less strict than Diffuse 3 trial. So it's also a match. So it seems like sleep perfusion study is a really helpful tool to help us select whether patient will be benefit from more aggressive treatment rather than just medical conservative treatment. However, there's some pitfalls when we are looking at CT perfusion study. So first, for ischemic core, it can be overestimated and it can also be underestimated. And how does this happen? So when the large artery, intracranial artery first being blocked, the blood flow will decrease dramatically. However, at this point, the brain tissue is not necessarily infarct, which means they are potentially still reversible, but the blood flow on CT perfusion study will be defined as ischemic core, which is less than 30%. So at this point, tissue is severely hypoperfused, but it's not really infarct. So we can overestimate the ischemic core at the early point when the large intracranial artery first being blocked. However, when the time goes through, the collateral blood supply will kick in, or maybe the patient have received intravenous TPA treatment, so the blood supply come back, the blood flow increase, but it's too late now because the brain tissue is already irreversible damaged. So at this point, even the collateral being recruited is too late. So we might underestimate the ischemic core. So this is an example for this. So this is the patient with large left MCA infarction who received TPA before arrived the stroke center. So we can see actually on left side, there's increased cerebral blood volume and increased cerebral blood flow compared to right side, right hemisphere, and also decreased mean transit time and decreased time to peak. However, on DWI MRI, which is the gold standard of ischemic infarction for brain tissue, we can see there's a large, extensive area of left MCA territory infarction. So this is because even the blood supply has come back, but the brain tissue is still irreversibly damaged. And regarding penumbra, it can be sometimes overestimated. So let's look at this example. So this is a 63-year-old man come here for CABG with underlying disease of AFib. He woke up at POR with expressive aphasia and right side hemiparesis and dysarthria. So the last known well is before surgery, which is 11 hours ago, and his head CT is normal. And let's look at his CT perfusion study. So there's no ischemic core and an extensive area of ischemic penumbra. So on this CT perfusion study, it looks like it's a really good candidate for aggressive treatment. And we can look at the original imaging. Oh, sorry. So we can see there's truly a large area of delayed Tmax. However, the cerebral blood volume and cerebral blood flow is essentially symmetric, which means, so that's why there's no ischemic core here. So it turns out this patient is a patient with chronic carotid artery stenosis, and the compromised blood flow is well compensated by collateral. So the point we have to remember here is that Tmax is time dependent. So when your major blood supply is being blocked and your brain tissue is being supplied by collateral, the Tmax will delay. But it doesn't mean that the brain tissue is have any ischemia happening. So we can see there's a large extensive area of delay Tmax, but there's no ischemic core here, which means the cerebral blood flow and volume is essentially the same. So cerebral blood volume is time independent. So when there's large area, when the brain tissue is mostly supplied by collateral, it will show up an overestimated ischemic penumbra. So the caveat is always correlate CT perfusion study with non-contrast CT, MRI, and clinical history. And another thing we have to know is that CT perfusion criteria is not well defined in patients with posterior circulation stroke, because all of these patients are excluded from Dawn and Diffuse 3 trials. And also there's a lot of artifacts when CT perfusion study being scanned at the skull-based level. And some older CT scanner is not able to perform the whole brain perfusion scan. And also CT perfusion studies has a poor sensitivity regarding detection of lacunar subcortical infarction. So we can look at this example. Can anybody tell me where is the lesion on this patient? Yeah, so it's really hard to detect on CT perfusion study if you are looking at lacunar infarction. So this is this patient's DWI sequence on MRI. So if a patient presents with a lacunar infarction symptom, you shouldn't rely on CT perfusion study for your management. And also CT perfusion study has a poor sensitivity for watershed infarction. So this is another example. We can see some difference between left and right hemisphere on the watershed area of ACA and MCA on left side. However, on the DWI sequence, there's only a little infarction here, which is not compatible with CT perfusion study. So when we suspect a patient having a watershed infarction, we should also not rely on CT perfusion study. And this is another case with a stroke code patient. EEG showed status epilepticus and in the left hemisphere. However, the subsequent MRI did not demonstrate any infarction. So on this CT perfusion study, we can see that on the left hemisphere, there is an increased cerebral blood volume and increased cerebral blood flow, and also decreased mean transit time and decreased time to the peak, which is also Tmax. So this CT perfusion study is actually caused by the hyperemic phase of post-ictal phase of seizure. So after seizure, brain tissue can be hyperperfusion, which will present as increased cerebral blood volume and increased cerebral blood flow on CT perfusion study. So if patients have a seizure and a stroke at the same time, we should be aware that seizure can mask the stroke on CT perfusion scan. So again, always correlate CT perfusion study with non-conscious CT, MRI, and clinical history. So to summarize, if a patient comes with a stroke symptom within 24 hours, he should receive CTA and non-conscious CT and also CTA or MRA. And if we find out there is any anterior circulation, large arterial occlusion, we can use down trial and diffuse trial to select the patient whether they will be benefit from mechanical or endovascular thrombectomy. And also we have to remember those pitfalls. So in the early stage of stroke, the ischemic core can be overestimated, and at the late stage, which is approaching 24 hours after stroke onset, the ischemic core can be underestimated, or after the revascularization. And penumbra can be overestimated in patients with chronic internal carotid artery stenosis. And also notice that CT perfusion studies should not be used in patients with posterior circulation stroke. And also CT perfusion study have a poor performance for lacunar infarction and watershed infarctions. And also remember that seizure can mask the ischemia on CT perfusion scan. And that's it. And I'm welcome to answer any question.
Well, thank you very much.